Thank you all for joining us. We are going to allow a moment for everybody to get logged in, and then we will begin the program with our moderators. Again, thank you all for joining us. We are going to allow just a moment for everybody to get logged in, and then we will begin the program. Welcome and thank you for joining us. We are going to allow just a moment for everybody to get logged in, and then we will begin the program. Thank you for joining us today. We are going to give everyone just one more minute to get logged in, and then we will begin the program. Thank you for joining us. We are now going to begin the program with our moderators.
Good evening, everyone, and welcome to the Eastern Pain Association fall webinar. I am Dr. Lisa Witkin, one of the co-chairs of our annual meeting, and we would like to invite all EPA members to please join us immediately following the Bonica lecture for a 10-minute annual meeting so that you can meet your new officers and directors. Next slide. We are excited tonight to have Dr. Stephen Cohen join us, who will be receiving the 42nd Annual John J. Bonica Annual Lecturership Award. He will be speaking about challenges in the design and interpretation of clinical trials in interventional pain medicine. Next slide.
Hi, everyone. Thanks for joining us. I'm Ely Huang. I'm one of the other co-chairs of the program. As many of you know, the EPA is one of the nation's oldest pain organizations that started in 1964 with an informal group of like-minded clinicians and researchers that gathered in New York. In the 70s, the IASP was formed, and Dr. John Bonica recommended that the New York group expand, leading to the formation of EPA. And it became one of the first chapters of the IASP. Next slide. We would really like to thank Veritas for sponsoring the webinar tonight. Before the Bonica lecture, please join us for a brief presentation on the treatment of painful lower extremity diabetic neuropathy.
Hello, everyone. Welcome and thank you. My name is Sundrut Patel. I'm a medical science liaison with Veritas Pharma. And with great honor, I would like to introduce you to Dr. Sean Lee, who would be presenting a different way to treat painful diabetic peripheral neuropathy.
Hello, everyone. I want to welcome everybody to the Bonica lecture series sponsored by the Eastern Pain Association and Veritas Pharmaceutical this evening. My name is Sean Lee. I'm a medical director at Premier Pain Centers, where I've been practicing interventional pain medicine in private practice for the last 10 years. Tonight, I'm extremely excited to share this platform with Dr. Stephen Cohen, who was an integral part of my fellowship training at Johns Hopkins and continues to teach me and inspire all of us in excellency in clinical research. Today, I want to introduce a new treatment option for the treatment of painful diabetic peripheral neuropathy. This portion of the lecture will not count as CME credit as it's sponsored. As all of you who know me, my personal interest is in neuromodulation, and this is a new novel way of treating a painful chronic condition using a neuromodulation technique that is completely non-invasive. We all know and remember utilizing capsaicin as a treatment option for neuropathic pain associated with postherpetic neuralgia. but the same treatment option is now FDA approved for the indications of diabetic peripheral neuropathy. Rather than considering this as a patch, I would consider this as a topical delivery system to allow us to achieve neuroablation. The transient receptor potential villonoid receptor, or the TRPV1 receptor, has been shown to be preferentially expressed on sensory nociceptive nerve fibers, mainly C and A delta fibers. This has been an area of interest because this receptor is responsive to the molecule found in the chili pepper, which is the capsaicin molecule. Binding of the capsaicin molecule to the TRPV1 receptor allows the influx of calcium. Prolonged exposure causes desensitization and eventual downregulation of these pathologic peripheral nerves, allowing desensitization and defunctionalization, hence decrease in chronic neuropathic pain. This can result in sustained pain relief until these nerve supply can be replenished over time. Hence, the treatment can be repeated with application of these capsaicin patches or system. So let's talk about the pivotal trial that allowed this new approval. The STEP study was a phase 3 randomized double-blind trial over 29 different sites, including 369 patients randomized to a 1-to-1 between the study Cadenza population versus placebo. A 30-minute one-time application to the feet was the treatment option compared to placebo. Patients were followed over a 12-week follow-up period. On the left side of the panel, you see that the percent change in average pain from baseline over a 12-week period was considerably higher in the Cadenza treatment group, illustrated in the purple line, compared to the placebo green line. And this is sustained relief. The percentage change was approximately 30%. On the right panel, in terms of responders, which was considered 30% reduction of pain, in the capsaicin group, this was reached far quicker at 19 days compared to the placebo group, which took 72 days. Overall, there was a higher proportion of patients achieving greater than 30% reduction in pain from baseline at 40.9% versus 31.7%, and that was statistically significant. In addition to sheer pain relief, a secondary endpoint was sleep interference. We all know that neuropathic pain, such as diabetic peripheral neuropathy, can affect a patient's quality of life in terms of sleep disturbance. In this particular study, Cadenza patches were shown to decrease the amount of sleep interference from baseline to weeks 2 to 8, as well as from baseline to weeks 2 to 12. Here you can see that the Cadenza patch population had a reduction of 33% in sleep interference versus 24% in placebo group. Similarly, from baseline to weeks 2 to 12, there was a 34% versus a 25% reduction in sleep interference. So we know that restoring sleep is a vital portion of pain relief. In terms of safety and tolerability, there was minimal adverse events. Main reports of discomfort were during the application process, where patients complained of burning sensation or application site discomfort. During the study, there were no reported of adverse events that led to permanent discontinuation of the therapy itself. Essentially, other than application site discomfort, there were no drug-related or treatment-related severe adverse reactions. So the use of an 8% high concentration capsaicin patch provided statistically significant improvement in pain relief compared to a placebo group for the treatment of painful diabetic peripheral neuropathy. This was well tolerated with minimal treatment-related adverse events. There were no discontinuations due to therapy. There were no deaths or deterioration in normal sensory perception. In terms of the additional safety information, these patches or application system is intended for handling by trained healthcare professionals and physicians. It's not intended for exposure to mucous membranes or eyes, respiratory tract, or cavities. It is intended to the treatment of painful peripheral neuropathy. You want to avoid any open sores or skin lesions. Aside from this, there are no contraindications because it's essentially non-invasive. In terms of other precautions, you want to make sure that careful removal and disposal of the patch so that there is no airborne contamination that may lead to unwanted irritation. The kit comes with a cleaning gel to allow for comfort as well as careful cleansing of the skin surface. The only recommended post-procedural step is to offer the patient a cooling pack for comfort. A key advantage of this particular treatment option is that it has absolutely no contraindication with any other existing treatment, including medications or interventions. In cases of uncontrolled blood pressure or hemodynamic issues, you want to have these sorted out before patients are treated with these applications. Again, I want to thank Averitas and Eastern Pain Association for the opportunity to share this news with you guys. Thank you for your attention, and I very much look forward to Dr. Cohen's presentation today.
So it's really my honor. This is Charles Argoff, and on behalf of the Bonica Award Committee, it's my pleasure to introduce Dr. Stephen Cohen. He's the Chief of Pain Medicine and Professor of Anesthesiology and Critical Care Medicine, Neurology and Physical Medicine and Rehabilitation at Johns Hopkins School of Medicine, Director of Pain Research at Walter Reed National Military Medical Center, and Mirror Professor of Anesthesiology and Physical Medicine and Rehabilitation at the Uniform Health Services at the University of the Health Sciences, and a colonel and retired colonel in the U.S. Army. This one line would be enough accomplishment for any one of us. This is just an amazing person. And Dr., we're so proud to have you here tonight, Dr. Cohen. He's going to be inscripted on the plaque that we cannot share, as Bill Schmidt said earlier, in person. Is the 42nd Annual John J. Bonica Annual Lectureship Award. It is presented to Stephen Paul Cohen, MD, in honor of his work in designing, conducting, and publishing interventional as well as non-interventional pain medicine clinical trials, and thereby significantly advancing the evidence-based treatment of acute and chronic pain. Dr. Cohen is well-deserving, and thank you so much for being with us tonight.
Thank you so much. Yeah, let me try to put these slides up. Thank you so much. This is really such an honor. you know, to be here, at least virtually, with you know, such good friends. Thank you, Sean, you know, for the talk before. Charles, Neil, Chris, I see Mike Weinberger on. Can everyone see my screen?
Not yet.
Not yet. Okay. Can you now?
No, not yet.
Okay. So I'm sorry. So I go share screen.
Correct.
Oh, right before it was saying this will stop someone else's screen share.
That's just fine.
Okay, so now you can see it.
Go ahead and click that share screen and then tell it you would like to share your PowerPoint.
Right, I just did this before.
There we go.
Okay.
And now you can click that full screen mode. That is perfect. Thank you.
All right, great. These are my financial disclosures in the past 3 years. These are the objectives of the talk. You know, to understand the perspective, the effect perspective has on evaluation of interventional pain outcomes, understand the differences between efficacy and effectiveness, learn to identify and eliminate different forms of bias, and to identify the limitations of placebo-controlled studies and their generalizability. So I show this slide in many different talks. How important is perspective? It's almost impossible to overestimate this. And the first time that I realized this, I was actually in New York in medical school in 1989, and on the front page of the Science Times of the New York Times, they had an article, and it was basically said that the Philistines were not only more technologically advanced than the Hebrews, but they were more culturally advanced. And this blew my mind, because as you can see here, you know, what did we know about the Philistines? You could see Samson, you know, pulling down the columns of a temple after being betrayed by the Philistine Delilah, and David slaying Goliath, who was about 13 feet tall in the Bible. And this is what happens in, you know, in medicine and in pain medicine. If you're an orthopedic surgery, you get almost all of your information from, you know, orthopedic spine journals, from meetings, from attendings. The people that you see in the spine clinic will usually have failed, you know, non-surgical interventions. And it's the same thing for, you know, for pain physicians. The people that we see, we're not seeing the successful surgical procedures. We're seeing the failed back surgery patients. We're reading, you know, pain medicine journals. There are very few really strong randomized trials that are published on the interventions that we do. Most of them are methodologically flawed, and you don't see negative methodologically flawed studies. So here are some examples. This is from the Lancet Low Back Pain Group. So I was an author on this, although the UK guidelines suggest consideration of radiofrequency denervation for chronic low back pain that's unresponsive to non-surgical treatments. The subsequently published negative MIN trials challenged this recommendation. And there were letters that were written on behalf, and the entire Lancet Low Back Pain Group recommended, you know, not doing radiofrequency ablation outside of clinical trials. And I was the only person that disagreed, and we actually changed the authorship and the recommendations based on this. This is from interventional radiologists. Facet joints constitute, you know, 15 to 45% of cases of back pain. So that's really clearly very high. Positive blocks can indicate facet joints as the source of pain, true, but very simplistic. And patients may benefit from facet joint neurolysis, notably by radiofrequency or cryoablation. Again, very complicated thing made simple. So here's a tale of 3 studies. The LeClaire study compared radiofrequency and sham denervation in 70 patients with axial back pain. They screened 76, which means that probably less than 10 people actually had facet joint pain. As the selection criteria, they required greater than 24 hours pain relief after a single high volume intra-articular block with lidocaine. So we know that intra-articular injections are not as good prognostically as medial branch blocks. And SIS says that if you get more than 24 hours relief, even with bupivacaine, it's more likely to be a placebo response than a true response. There were lots of technical problems with this. The study was negative, but you could see the values below here. The methodological quality score out of a 5-point JADAD scale was 4, and the clinical relevance was 8 out of a non-validated scale by Wertz that's 20 years old. NATH study compared radiofrequency denervation to sham in 40 patients. They screened 376 patients. Very strict selection criteria, greater than 80% relief after 3 blocks. They created 6 lesions without stimulation, and radiofrequency was superior to the sham treatment for all outcomes. Yet you can see here the methodological quality was the same, the clinical relevance was lower. And the MINT study, this was not an efficacy study. They compared radiofrequency to standard exercise in 251 patients with axial low back pain. They required greater than 50% relief within 30 minutes after a single lidocaine block. A very large majority had positive blocks, so that's a problem there. There was no personalized approach. Everyone got L3 to L6 blocked. There were actually 3 studies, an SI joint study and a discogenic study, and people sometimes went from one to another. They had SI joint blocks that didn't work, then they had discography that didn't work, and then they went facet. So these are different conditions. They created tiny lesions. There were no significant differences between radiofrequency and no radiofrequency at 3 months. This was misinterpreted as an efficacy study. And you can see here the methodological quality is lower, but that got published in JAMA. So this is from something that we published in Regional Anesthesia Pain Medicine 2016. This is a technical quality scale. This is really important because technical quality is probably more important than methodological quality for, procedures. Are we selecting the right patients? Are we doing them correctly? So you can see from the Cochrane risk of bias, methodological quality includes random sequence generation, allocation concealment, blinding of all people involved, people even blind statisticians, and being transparent with reporting. Technical quality concerns, are we avoiding co-interventions, including medications, additional procedures? For epidural steroids, because this is Aquarius, do patients really have herniated disc or spinal stenosis? Is that causing their pain? We need to measure, leg pain and or, arm pain. If we measure both of them, they should be measured separately. For efficacy studies, we want to avoid people who are likely to fail, those with psychopathology, secondary gain, non-organic signs. We just published something on that. Patients with, pain for 2 months or 6 weeks, they're very likely to get better with epidural steroid injections. But that's part of the problem. They get better even with sham injections or no treatment. And although injections don't have to be standardized, there should be enough patients to look at subgroups. So this is from our 2013 paper. So the first 2 columns go over the results of randomized controlled trials stratified by the corresponding author. So who did the study? And as you can see here, if studies were done by pain physicians, 3/4 of them reported positive outcome versus about 30% for non-pain physicians. And I get it. We do these procedures very well. Perhaps more importantly, we select the appropriate candidates. But look at the review articles, systematic and evidence-based review. This is really hard to reconcile. Over 90% of of reviews done by pain physicians conclude that epidural steroid injections are very effective, versus about 1/3 for non-pain physicians. And the reason that that's hard to digest is because we're looking at the same randomized trials using the same or similar grading scales, and we're coming up with different conclusions. So this is a problem. This is the New England Journal of Medicine study on epidural steroids. They took 400 patients with spinal stenosis and they randomized them to epidural steroids and local anesthetic or local anesthetic alone. They had a conference call beforehand and they said, you know, we're going to bill Medicare and insurance companies for the local anesthetic, i.e. the SHAM injection, because it's not really a placebo. They didn't, you know, standardize injections, yet steroids were better than local anesthetic at 3 weeks, and they were very close to being better at 6 weeks. This was not a great efficacy study. They included patients, you know, really at high risk for failure, those on high dose opioids with long duration of pain, psychopathology. Yet they concluded that epidural steroids offered little or no benefit for spinal stenosis. But the interventionalists in the group, they all really disagreed with the interpretation. So I think that, you know, there's a little bit of bias when looking at interventional trials. This is an example about integrative medicine. Does acupuncture increase pregnancy and live birth in females undergoing in vitro fertilization? So this was published in a really high impact journal. This had enormous media attention. They looked at 7 small studies. They inserted needles at sham points, real points not breaking the skin, sham points not breaking the skin, or no treatment. And that's very complicated because the people who go to an acupuncturist go because they want acupuncture and they believe in it. 4 out of these 7 studies were negative for pregnancy, 2 or 4 for live birth, yet they concluded in the British Medical Journal that it increased the chance of pregnancy by 65%, and 1 in 10 people who were treated with acupuncture would get a live birth. So the British Fertility Society, you know, was really inundated with problems. They, you know, analyzed 14 trials. They concluded there was no evidence for acupuncture or Chinese herbal medicine increasing the chance of a woman getting pregnant. So why is this important? So we have a series that's going to be coming out in Lancet. We're having a problem with the 3rd article on neuromodulation, but the first 2 are accepted. And there are 2 versions of the first article. One that includes the NICE guidelines and one that doesn't, because these are preliminary. So the NICE guidelines in 2020, again, these are not finalized. They recommend exercise, no problem, cognitive behavioral therapy and acceptance and commitment therapy. They recommend consideration of acupuncture. They state that there's more research needed on manual therapy, but the only medication that they recommended was antidepressants. So they recommended against anticonvulsants, steroid and steroid injections, opioids, ketamine, which is in contrast to other guidelines. The problem, you know, when we had a conference call with them is that these aren't really personalized medicine guidelines. So there's very, very large standard deviations for pain treatments, specifically for injections. And yesterday, I actually saw the father of a guy who's considered, I guess, on the very, very short list for becoming the new director of the FDA, and he's interested in pain. And we were talking about an epidural steroid for his father, and I said, you know, if I was the only pain doctor in Baltimore doing epidural steroids, everybody would get better because I would only have enough time to pick the best candidates. But if there are 40 people and these people have to send their kids to college and pay for staff and office space, then they're going to start to decrease the selectivity, and they're going to take people with long-standing pain, with axial back pain, people with failed back surgery syndrome, and very few of them are going to get better, but there's going to be large standard deviations. So statistics can yield different conclusions from similar data and be presented differently. You can see the first thing here, you know, more preschoolers than cops get shot dead, but there's way more preschoolers. And you could see the COVID thing, right? The US doing more COVID tests than every other country combined. Well, it's not combined, but, you know, we're definitely not doing more COVID tests on a per capita basis, but we have larger populations and a larger population and more resources. So this is a study. This is the first study that we published in Annals of Internal Medicine. We compared 2 epidural steroid injections to 2 etanercept injections to 2 saline injections in patients with subacute sciatica. We sent it to Annals of Internal Medicine, which they consider themselves the most statistically rigorous journal. And so the first time we submitted this, we used ANOVA, and the p-value you can see for the primary outcome, leg pain, was 0.07, and for functional capacity for 0.03. So the journal came back and they said, we want you to consider, different covariates like gender and, duration of pain. So we did. We used ANCOVA, very, very popular. We came up with very different p-values. So we used multiple regression. So this was the chair of the IRB at Walter Reed. So very, very sensitive to tech differences, includes interactions, and you could see the p-value for the primary outcome was less than 0.001. Everything was statistically significant in favor of epidural steroids. The journal came back and they said, we'd like to have a conference call. We want to use ANCOVA. It's very conservative. We want you to consider these things. We analyzed the data again, and you could see very different. Leg pain, barely a trend towards statistical significance. So the article came out, there was a press release, and I spoke on the phone with a guy, Nicholas Bacalar, and this is probably the second or third time that he had done something on one of our articles. And I explained, our feeling, what the discussion is. Nick had had 3 epidural steroid injections without really having radiculopathy, and he was not impressed with the procedure. And this is kind of what was published in the New York Times in print. So efficacy studies are highly controlled, methodologically robust. These have long lists of inclusion and exclusion criteria. You generally need a placebo, whereas comparative effectiveness studies should utilize more liberal selection criteria. These are easier, they're less expensive to do. They don't even need to cost money. Efficacy studies are time consuming and they're expensive. Effectiveness studies should include more sites, longer follow-ups. For efficacy studies, we really want the best practitioners. We want to treat the ideal patients. We want short follow-ups if you want to maximize the chance of detecting differences. Whereas comparative effectiveness studies consider utility, speed, tolerability, sustainability, costs. Comparative effectiveness studies can result in false negative results for an efficacious treatment. So we don't want to throw the baby out with the bathwater. Efficacy studies overestimate benefit in real life, whereas comparative effectiveness studies more closely reflect what we see in our practice. So how important is selection? So this is very complicated. I looked at radiofrequency ablation studies, and I classified them into successful ones, or negative studies and positive studies. And what you can see here is the studies that selected patients with more stringent criteria were more likely to be positive. So the enrollment rate for positive studies was 14%. So it was much less for the negative studies, 29%. When you design a study, you want to define your objective. So for diagnostic accuracy, that might be for surgical prediction, you would want to use intra-articular facet blocks, very low volume. You'd want placebo blocks, and they need to be done under CT. You would come up with a low prevalence. If you want to prove efficacy, you would want to do double, maybe triple medial branch blocks with a placebo control and use a very aggressive lesioning strategy. Again, you would have a very low enrollment rate. If you want to maximize success, you probably wouldn't perform medial branch blocks. You might use paraspinal tenderness, which is sensitive, but it's not specific. I go over this all the time when I act as a journal editor. So, large data, big data is very important for identifying responders, but it's not perfect. For example, if you're looking at opioid use and radiofrequency ablation, and you had a database of 5,000 people, you might find that people on opioids were 2 or 3 times more likely to fail radiofrequency ablation. And studies show that it's even greater. But if you had a randomized trial or an adaptive design, you might find that people who don't receive radiofrequency ablation are 5 or 7 times more likely. So you would actually conclude that people who are on opioids should receive radiofrequency ablation. There's lots of differences between, clinical trials and practice, and design should be contingent on the question being asked. So again, for efficacy studies, very stringent criteria. So think about this. For epidural steroid injections, they have a study that was designed with input from the FDA that required over 300 patients. And there are 2 radiofrequency studies that require between 300 and 400 patients compared to placebo. So most of the studies out there compare 2 different types of steroid, or maybe different radiofrequency techniques. So they're comparative effectiveness studies. So if 350 patients are needed to establish efficacy for radiofrequency or ablation, how many people, almost certainly over 1,000, would you need to detect a difference between selection, between different techniques? Frontline practitioners have different goals than researchers, and you can see here, in the FASEC guidelines, some differences. And the one that I'll mention is, for a clinical trial, insurance companies are not going to pay for radiofrequency unless people have failed conservative treatment. That's consistent with almost all guidelines. But in clinical practice, that might not be the right choice for some people, for someone who is incredibly busy, for military personnel who is, on a deployment, somebody who ran a Fortune 500 company. There's lots of barriers to conducting interventional pain research. There's costs, and we run into that now. So the Affordable Care Act says that if that Medicare should pay for treatments if they're standard of care, but there's different criteria for different Medicare carriers. So we have a $16 million NIH grant that we're trying to start up this month, and we're having problems because carriers on the West Coast require genicular nerve blocks, whereas some carriers on the East Coast will permit it without them. Blinding, I'll go over this. Interventions that involve neuromodulation, ablation, injection around a nerve can be difficult or impossible to blind. Designating a control group, and I'll go over this in more detail later, but when we do these placebo control injections, often the control is not truly inert. We know the procedures are associated with a much stronger placebo response than medications, which reduces statistical power. It's hard to recruit people for a sham controlled study, and internal review boards may have problems with this. So, efficacy studies measure benefit and harm in closely monitored research studies. So these minimize bias, they have high internal validity, but they're often not generalizable. Effectiveness studies measure benefit and harm in everyday practice. So these are often observational studies. They're dirty, they have high external validity, but they require a lot more patients. So while heterogeneity increases generalization, it significantly reduces power, and the NIH has problems with this. Efficacy asks, does this work in clinical trials? Effectiveness, does it work in clinical practice? But the important thing is, where in the continuum of care does something fit? If it may work, but where does it come into play? The placebo effect is really the 800-pound gorilla. The placebo effect is enormous for pain treatments. Probably the only thing that might be higher are, placebo effect to treat psychiatric conditions. There's lots of things that affect it, including, physician, doctor expectations, the strength of the relationship. Brand name drugs have stronger placebo effect than generic drugs. Patient contact, conditioning, genes, procedures more than pills, adults greater than children. That's why if your son or daughter, scrapes their knee, you could put a Band-Aid on it and kiss it, and it's better. The placebo effect decreases with time, but expectation bias can increase with time. And placebo effect, despite what people think, can last for months or years, often the same amount of time that, the procedures that we do can last. So here are some things that show the procedures have a stronger placebo effect than pills. In a meta-analysis of 22 trials to treat acute migraine, the response rate was 32.5% with sub-Q versus 25.7% with oral medications. Ted Kapchuk did a great study. He's really a leader in this area. Looking at comparing sham acupuncture to placebo amitriptyline, as you can see from the graph here, sham acupuncture is more effective. And Zhang, in a meta-analysis including 7 trials, found that sham acupuncture was significantly better than routine care for pain, and it fell just shy of significance for function. So a strong placebo effect makes it really difficult to detect the same absolute difference. So think of this: if a difference of 4 versus 2, if the placebo effect is 2 and the treatment effect is 2, versus 52 versus 50. What this translates to is that the same magnitude effect has greater benefit to patients. So the number needed to treat for placebo is actually lower than it is for the best drugs, which means it's more effective. This is a fact. All you have to look at is almost any placebo-controlled trial, and you could see that the within group difference for the placebo group is greater than the between group difference. And it can be repeated with the same efficacy. Even if you look at functional imaging and you had people who were given Neurontin or placebo, you would see, greater similarities between responders when one got Neurontin and one got the placebo than, in 2 people who got Neurontin where one person got better and one person didn't. So if the duration and magnitude of pain relief and functional improvement is the same or probably greater for placebo than treatment, is it important? Is it even possible to distinguish the contributions of each? So these are examples of active control treatments: insertion of acupuncture needles at wrong points or non-point, epidural non-steroid injections for epidural steroid injection studies. So we know that transforaminal injections are probably more efficacious than interlaminar. But when you do transforaminal injections, people feel it in their legs. So the choice is, should you do a placebo injection where you're giving them saline or local anesthetic, epidurally, which is likely to exert a very significant effect, or should you do an intramuscular injection, in which case people can tell which treatment they got? Medial and lateral branch radiofrequency studies. So you need to give these people, local anesthetic beforehand, not only to blind patients and make the procedure more tolerable, but also to increase lesion size, and steroids, according to our FSEC guidelines, to decrease neuritis. But we know that a certain percentage of people, if you give them, medial branch blocks with local anesthetic and steroids, will get long-term relief. The two 2009 New England Journal of Medicine vertebral augmentation studies, they were criticized because both of them used high-volume facet blocks right at the pedicle, and intra-articular non-steroid injections for joint injections. So how can you reduce the placebo effect? Well, minimize staff interactions. We usually have, video presentations before, so startup videos. You can shorten or extend the length of the study, hoping to extinguish the placebo effect. Blind evaluators. You should have a run-in period with pain diary. So if you had a range of between 4 and 9 to enroll out of 10 to enroll someone in a study, it would not be normally distributed pain scores. They would be, kind of clustered around 4. But if you had 5 or 6 to 9, they would be clustered around 5 or 6. So the evaluator who determines if patient gets into the study should be blinded, because otherwise a lot of people who would normally fall short would meet criteria. And you want to avoid patients with wide variations in pain and psychopathology. And there's several studies now that show that wide variations in pain, of course, make it more statistically difficult to detect the same difference. But there's also substantial literature that suggests that these patients are more likely to be placebo responders. So two really important studies here. The first one was ours in 2013, and that same guy, Nicholas Bacalor, wrote another article in the New York Times about it that I would disagree with the interpretation. So, epidural injections were used in the late 1800s to treat back pain. The first studies were published just at the turn of the 19th century. And steroids were discovered in 1948, and it wasn't until 5 years later that the first description of steroids to treat, sciatica was used. So for more than 60 years, people were using epidural saline, epidural local anesthetic, and getting good results. 1970 was the first epidural steroid injection controlled trial by Swerdlow. And since then, there's been, 50 of them, and no one distinguishes between the control group. So do they get epidural saline or local anesthetic, or do they get intramuscular injections? So not distinguishing what the control group is means, that a lot of these studies are underpowered because they're actually comparative effectiveness study. So we decided to compare the control groups, and what we found is that at the first follow-up visit, more than half of the effect, a lot more than half of the effect of epidural steroid injections have nothing to do with steroids at all. And this is a study that was just published in the British Journal of Anesthesia by Harshit and Thana. And this was larger. It was a meta-analysis containing almost 3,600 patients. They found that adding steroid to local anesthetic for a whole host of injections, epidural steroid, joint injections, nerve block, very, very slightly increased the success rate. So you had to treat 13 patients for one person to benefit from steroid above local anesthetic. And when they removed 2 outlier intrathecal studies, you had to treat 22 patients. And the difference between steroids and local anesthetic overall was not statistically or clinically meaningful. So it's important to get the control group correct. So this is a parody, in the Christmas edition in BMJ, very famous, right? The systematic review, parachute used to prevent death and major trauma to gravitational challenge. And you can see the conclusions here. Parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized trials. So we don't really have a lot of data to show that larger radio frequency lesions improve outcomes. But it's almost deductive reasoning, right? Because radio frequency works when we correctly target the nerve. If we use larger lesions, we're less likely to miss the nerve, hence you may not need a randomized trial. So again, there's other ways to prove things, deductive reasoning, whereby the conclusion is a logical response to the premises. So if we assume that surgery works, decompression surgery, and it works better when surgeons operate on the correct level, and if we know that selective nerve root blocks increase diagnostic accuracy, then you don't need a randomized trial to show that they're effective, although we have some studies. Inductive reasoning is a little bit more challenging. So if traditional auricular and electrical acupuncture are effective, it doesn't necessarily mean that hand acupuncture is. It may be not. So there's some outcomes that are not amenable to placebo-controlled trials, a rare complication, such as death after cervical transforaminal epidural steroid injection. We would need, tens of thousands of people to show it. Or a condition with a very high success rate, like acute low back pain. That's why these people shouldn't be enrolled in studies. On the flip side, now come with very low success rate, like 10-year survival for pancreatic cancer, or, looking at return to work in somebody on long-term disability. And the same thing, for conditions with reliable treatments and dire consequences. So we know that surgery, works for Carter-Aquina syndrome. And we know that because people with Carter-Aquina syndrome who don't have surgery do really poorly. Lots of sources of bias in a clinical trial selection. This has to do with, randomization and allocation. And it's challenging now because, a lot of journals, stylistic, the way that you could tell if randomization and allocation are successful is you look at baseline characteristics. Are they similar? And now, a lot of high impact journals don't want p-values reported for baseline data. Information, you need to blind, patients, care providers, data collector. And I actually agree with Annals of Internal Medicine when they say, don't use the term double blind. Say who is blinded and how they were blinded, and analytical. So intention to treat analysis, I'll go into more about this. So again, random sequence, you can tell this by, equality of baseline characteristics. There's lots of things to avoid. For example, the first randomized trial to look at whether epidurals prevented phantom limb pain, they just randomized people based on date of birth. Allocation concealment. I like to use, high numbers of block randomization, but 3 weeks ago, we just got a randomized trial looking at intradiscal steroids approved. And the scientific review committee said, please, we want smaller blocks. Blinding of outcome assessment, as I went over, it's not always possible to blind interventional studies. Incomplete outcome data, attrition bias, selective reporting. That's why people use intention to treat analysis. And I'll go over a little bit more of that later. And analyze predefined outcomes. So this is why we have to register trials. And probably at some point in the next few years, many journals are going to require protocols to be submitted. And a lot of them require, almost all of the high impact journals like Lancet, BMJ, New England Journal of Medicine, before the article is accepted, they want to see protocols. They want to see, statistical plans and how they've evolved. So this goes over the proportion of positive studies. And you can see psychiatry, psychology, and pain have really the highest proportion of positive studies compared to things like space science and geosciences. So we have over 100, studies published each month about pain, and almost all of them are positive. So this leads to interesting questions. Why aren't we getting better outcomes? So disability rates, haven't gone down, and when they've looked at these, prevalence rates haven't gone down either. They've gone up, although that probably has to do with surveillance. So something is wrong. Negative studies are less likely to be submitted for publication and to be published. And I'll just give you one example. So the IASP has a neuropathic pain special interest group, and they had made recommendations about 10 years ago. But in the 2015 recommendations, they started to look at data registries and industry websites. And so they were including studies that weren't published. And this significantly changed the numbers needed to treat and their recommendations. John Ioannidis, very famous in this area, examined reproducibility of results in 49 trials published in high impact journals. In 16%, the results were refuted. In 16%, they found stronger effects. In a little bit less than half, they were replicated, and about a quarter remain largely unchallenged. A p-value of 0.05 has about a 25% chance of being untrue under perfect circumstances. So many journals, and this they go back and forth, every few years, say we need to lower the p-value. So few well-conducted studies with p-values less than 0.005 fail to be reproduced. So more things. Top scientists at Amgen tried to reproduce landmark cancer studies. Very, very few. About 15% were reproduced. And the same thing with studies from Bayer scientists who tried to reproduce oncology, women's health studies. Again, less than a quarter were reproduced. So this is, again, a perfect scenario. So let's say that you had 1,000 hypotheses and 100 were true. And we have a p-value of 0.05. That means that there will be 45 false positives, right? 5% of 900. And let's say you powered a study to 80%. And I always recommend, higher. You don't want to go too high to 99% because then you can conflate statistical significance with clinical relevance. So that means that you'll confirm only 80 of the 100 true positive studies. So there'll be 20 false negatives. So you don't know anything, right? You just see p-values. And so you'll see 125, positive studies, but 45 of them will be false positives. So what about overpowering a study? Why don't we, power studies to 95 or 100%? Well, first of all, it exposes patients to unnecessary risks. It utilizes resource. It increases the chance of not completing the study. We published something in 2010 looking at over 40,000 evacuees from theaters of operation in Iraq and Afghanistan. It was the cover article of a special edition of Lancet, and everything was positive. So we looked at return to duty rates, and if you were enlisted versus officer, positive. There was a difference. If you were Army versus Navy or Army versus Marines, there was a difference. If you were junior enlisted versus senior enlisted, there's a difference. But it doesn't mean that it's clinically, meaningful. So again, 96% of medical abstracts, that include p-values of less than 0.05. Most of these will be false. So, a p-value of 0.05 doesn't mean that what you say is true. So a p-value enables you to you can either reject or fail to reject the null hypothesis. You can't say that something is true. It doesn't measure, effect size, importance of finding, or provide a good measure of evidence. When you look at population genomics, which contain enormous numbers of patients, they have, p-values that are just infinitesimally small. So if we change p-values to 0.005, a third of these significant findings would be shifted to suggestive. So this is a problem in people who see things discretely, like black and white, without seeing, without seeing gray. And it's especially a problem for interventional trials where it's really, really difficult to get these very, very low p-values just because of the number of patients that you enroll. So very little of what we do is evidence-based medicine. So I want to point out here, that evidence-based medicine is not just, randomized trials. So the original definition, includes consideration of physicians' judgment, what they feel most comfortable with, and taking patient values into consideration. So for, like I say, about 15% of conventional medicine is evidence-based, but for integrative and interventional medicine, it's about half of that. So because the placebo response, again, is greater than the intrinsic effect of most treatments, if you were looking at, traditional Chinese medicine, it might work better in Chinese people. I lived in Korea and everybody went for acupuncture. It might work a lot better than if you were trying to treat, people in Appalachia. Blinding is essential to eliminate expectation bias, but as I said, placebo effect is an integral part of the treatment. And I went over this before, how it's difficult to blind, interventions. So how important is it to blind interventions? Well, non-blinded assessment of randomized trials exaggerates the effect size by 33%. When people state that studies are blinded, but they're not likely to be blinded, they're still probably at least 20% more likely to yield effective results. But this is more than double for pain, and that's because pain is a subjective outcome. It also increases heterogeneity. And last week we just had this call with the NIH for grants, and I was there to present our knee radiofrequency ablation study. But there was a friend who was presenting data on ketamine, and so they asked me, and I said, you can't really blind ketamine studies. In the Sigderman study, which was probably one of the best ketamine studies, out of 30 people who received ketamine, 28 people successfully guessed their treatment allocation. So subversion bias occurs when researchers manipulate recruitment. Again, you can see the baseline data is not equivalent. It's more likely to occur with small block randomization. This is more prevalent than believed. like I said, it's very difficult to explain like how all of these studies are positive, but we don't really, or we're not moving the ball that much for pain. Hewitt examined 234 randomized trials published again in these top 4 general medical journals. 56% reported adequate, 26% unclear, and 18% inadequate concealment. And when they looked at the difference between adequately and inadequately concealed trials, that was statistically significant by itself. So, you know, again, randomized trials inherently difficult to blind. As randomized eliminates investigator bias compared to as treated or per protocol. You know, it really, you know, analyzes subjects regardless of compliance, whether they receive treatments. The problem with like, you know, intention to treat is it can include patients who never received treatment, but it is recommended by most organizations. And I'll give you an example of this. People are probably familiar with the sports studies, right, which almost saved spine surgery in the United States. They were published in New England Journal of Medicine, JAMA. They compared surgery to not having surgery for a whole host of different problems. And, you know, for the spondylolisthesis and the herniated disc studies, you know, the as treated analyses were strongly positive and they were not significant with intention to treat. The problem was that more than 40% of patients were non-adherent to treatment. So if you were randomized to surgery, over 40% didn't receive surgery. And if you were randomized to not get surgery, you ended up getting surgery. So what does it mean? Assumptions about, you know, missing data. So missing completely at random is unrelated to any variable. So for this, you can just completely ignore missing data. Missing at random means that the outcomes are related to recorded variables. So you can basically impute or guess the results based on similar subject. Not missing it at random is more problematic. So it means that there's a strong likelihood that unrecorded data, i.e. disease progression, you know, affects outcomes. Last observation, not, you know, carried forward, used all the time, but it's not really valid for missing completely at random. Baseline observed carried forward is extremely conservative for pain studies because it assumes baseline data. That means nobody gets better. But let's say you were looking at cancer study. That would be very, very liberal, right? Because cancer study, we're trying to see if people progress. So if you just take their baseline data and move it forward, it's like I said, you're assuming the best. How to the top journals handle missing data? Well, 95% report missing data, so not everyone does. Almost 50% handle it with complete case analysis, so they just drop people who don't. 27% with simple imputation, 19% with model-based methods, and 8% with multiple imputation. Most use either intention to treat or modified intention to treat. Sensitivity analysis is really important if you're you know, imputing, because you're making assumptions. And if you want to know if these assumptions are correct, what you can do is you can change the assumption. So we're going to make this assumption and we reach this conclusion. But what if that wasn't true? What if this assumption was true? And you compare these things and you want to see if they're the same. This is a great example that there is you know, a typo over here. So let's say that you're trying to see if a weight loss drug worked. So people were getting this in, you know, Weight Loss Anonymous or Overeaters Anonymous. So these people want to lose weight. So they're trying to diet and they're trying to exercise. You take 150 people, 75 get the real drug, 75 get placebo. So in the people who get placebo, they're going to be less likely to go back and get it, right? So a lot of people who get placebo are going to get better because they're trying to diet, they're trying to exercise, they're going to lose weight no matter what. But more people are not going to show up. They're going to drop out because they didn't get better. They say, this doesn't work. I need to get a different pill. I need to try this thing. So if you're just looking at doing a per protocol analysis, you will not see a you may not see a statistically significant difference when there absolutely is a statistically significant difference. And that's because dropouts are more common among people who fail treatment. So how do you reduce dropouts? Well, you can target a condition not adequately served by treatments. That might consist of a lot of our things. You can allow the use of rescue medications, but that's fraught with problems, because if we give people tramadol, as we do in our SCOPE trial, if they take enough tramadol, they'll feel better, but it won't be attributable to the treatment. You can allow a flexible treatment regimen that accommodates, individual differences, i.e. personalized medicine. You can include a run-in period where only individuals who tolerate a treatment undergo randomization. Some even do with people who've responded. So this is an enriched protocol. The problem is it reduces generalization and dramatically increases the response rate. You could also shorten the follow-up period again, but that's less clinically relevant. So what are the trends in clinical trials? And I'm nearing the end. So they're getting increasingly complex. So for the NIH, there's a 1-year preparation period before startup, but for the DoD and the VA, it's 2 years. Patient studies are becoming more patient-centric. Even without COVID, they're becoming virtual. We're using adaptive studies, so you can alterate, you can change trials based on real-time data, so you can drop arms, you can adjust randomization ratios, you can adjust the power analysis. These things are all fraud. We're using more big data analytics and mandatory registries. Again, there is a big problem. I can give a talk on this, with fraud and data in studies, especially animal studies, but human studies, absolutely. And so now in studies, for these studies that I lead, I don't even see the data. I have no control. So blockchain, people know what that is. It establishes a time-stamped chronological record of history that can't be tampered with. Data now from government funding is publicly available. So you can apply to get access of the data. And a lot of these top journals say, the data is available. Precision medicine can include different treatment options for different subjects, or it reflects real life. Artificial intelligence modeling. They can be funded networks to facilitate recruitment, patient planning. This is probably very important for neuromodulation. Like I said, we're doing there's a neuromodulation article coming out in Lancet, and they lick askance on some of the studies that are industry sponsored. But these treatments work. But if everyone would put together, donate to the foundation that Charles leads, it would lead to more credible results. So again, not only trial registration, but protocols and statistical plans are going to be published online before inception. That's my prediction. And there'll be pooling of resource for more representative studies and more global studies. This is done in Europe. So in conclusion, logistical and practical concerns have led to evidence gap in pain medicine relative to other specialty. And this is more so for interventional and alternative treatments. There's got to be a lot of attention to design, so early crossover for controls and more comparative effectiveness studies that can minimize ethical concerns and enhance enrollment. For some treatments, we're going to have a shrinking reimbursement pie, and this underscores the need for better research, and it might mean more competition for patients. And again, for designing efficacy studies, and these are needed early on, we have to really, refine selection criteria. And that's the end of my talk. Thank you very, very much, everyone, for having me.
Thank you, Steve, for a great talk and very impactful, albeit a little bit mind-boggling on the amount of work that needs to go into designing studies. But thank you again, and congratulations on the award.
Thank you. Thank you very much.
And I'll check with our moderators. Are we moving on to the business portion of our meeting at this point?
Yes, we are, Dr. Mehta.
Okay. So with that, I invite our EPA members to stay on for a brief business meeting. And for those that not staying on, we thank you for being part of this. And we also thank Veritas for sponsorship of this meeting and Mantra for helping organize it. Again, my congratulations to Dr. Cohen. And we will now begin our business aspect of the EPA meeting. Give a moment for people to log off those.
Yeah, I'm trying to answer. Right.
So I guess Chris, if you want to take the lead on the business portion, and then we'll proceed.
Sure. Can everybody hear me okay?
Yes.
Yes.
Yeah, I just want to take a couple of minutes before I hand it over to the meeting. I'm proud of the EPA and what we have accomplished in the last 2 years. We have given, what we have accomplished in the last 2 to 4 years is that we've given young physicians a solid platform, not just to learn, but to also reach out and decide their next fellowship and exercise leadership and further their careers. Special thanks to Lori. She was very helpful in sort of, I guess, in bringing it all together, Lori, right? She certainly accomplished that, and thank you, and we appreciated your support. And I guess that's been the motto for EPA too. We were interdisciplinary society. We brought it all together, but I think we kind of evolved where we sort of evolved into where future of pain medicine starts. We're getting young physicians into our platform, and that's part of our challenge too. How do we get the younger physicians into the platform, and how do we keep them? Because it's a dynamic niche, and as it becomes successful, I think we need to find a strategy to keep them. And it could be very laborsome to do that, and that's going to be, I guess, one of Dr. Mehta's challenge. I think we accomplished quite a bit. I did what I can in having us survive the crisis. We had successful annual meetings. We separated from APS. We converted our legal status from C6 to C3. We had a successful Meet the Program Director series. And I think, we went sort of national with that as well. We had participants from the East Coast and the West Coast. And I think that's something that can be followed up by Dr. Mehta as well. I thank everyone for their support and guidance and counsel. And I'm looking forward to working together with Dr. Mehta and all of you in the next 2 years.
Chris, we thank you for your leadership, and it's been an honor to serve with you as your role as president. And we look forward to having you continue to contribute in immediate past president status. I can say that without a doubt, I can't imagine any president has faced the challenges that you have faced in these 2 years with some of the controversies and pandemic related things. And you have led it beautifully. And again, I thank you for your guidance through this.
Thank you, Neil.
Normally, I guess we would hand you a wonderful award, and I'm hoping that my words allow you to at least hear our gratitude from all of the board to you. So with that, I guess, do we turn it over to Bill now to share?
I think we move next into, I think next we move into the Treasury report and then the membership report.
Okay, I stand corrected.
Yes. Let's see here. Can everyone hear me fine?
Yes.
All right, fantastic. Good evening, everyone. And what a wonderful presentation we had. Kicking off the Treasury report, we had starting balance of the year 2020. We started off with $45,300, which was similar to the year before. And we also had the $10,000 in our Bonica CD, which we rolled over 13-month CD at 3% APY, 3% interest rate. We closed the year with an ending balance as of yesterday of $29,614 with the Bonica CD in place at $10,200. Additional income anticipated is $5,000 for the Veritas Bonica webinar that we just had. And expenses remaining are another $2,250, which include the honorarium and the webinar production fee. In short summary, this year we'll finish with a little more than $32,000, which does not include the Bonica CD. Very similar to how we started off in 2018. Those are the main points. Does anyone have any questions?
No questions. Thank you.
Okay. There's one thing that I think is important just to bring up. Our CME credit for the 2020 meeting, which we rolled over towards NYU, that's going to be due next year, which is, I believe, $7,500. So the CME with regard to the meeting that we had initially planned for will still be active. And that is something that we should consider how we're going to, are we going to actually take advantage of the CME credits that we filed for, which they essentially told us that they'll honor for 2021 on the year moving forward. So just a little tidbit there. Otherwise, that essentially concludes the Treasury report.
Great. We hope that we'll have the opportunity to do a meeting. Hopefully our coming out of the pandemic will open up the opportunity for meetings this fall, if not earlier.
Certainly.
And then do we have a report on the memberships?
Yes, I give membership reports of the EPA 2020. Currently, we have a little over 200 members, 202 to be precise. Here's the breakdown. We have 30 sustaining members, 6 lifetime members, and we were able to create opportunities for the young physicians to come together and make things for pain medicine field itself. And for future patients, we have 128 training members, which include majority of them resident physicians, fellows, and some of them being student physicians, including 50 people that were recruiting from this year's webinars recruitment. We have 31 regular dues paying members, and we have 7 with unknown status. I'm not sure they're training or attending, and we have sent inquiries. And for the 31 regular dues paying members, electronic invoices for 2021 dues went out on November 16th, 2020. To date, to have paid, and then paper invoices will be mailed to the remainders. And that pretty much summarizes the EPA's 2020 membership report. And then moving on to the next website, social media forum committee. We created number 1, an interactive forum for current and future pain medicine clinicians and scientists. We have integrated all social media platforms, including Facebook, Twitter, and Instagram. And so any posts that will be going moving forward will be all integrated, and through each platform, events, all APA related events will be co-promoted. And then the rest of the updates could be filled in by Dr. Yu Chu, if you're there, or Dr. Peter Lescarides or Dr. Hunt.
Yeah, so I have some figures. As of December 1st, we rolled out our EPA forum, which certainly looks crisp. So far, we have 2 posts, which were posted by Dr. Chu, and there's a comment. It seems like there have been 18 views. Regarding our Instagram, we have 672 followers with approximately 10 to 30 people engaging regularly on our posts. Facebook, 105 following, with similarly 10 to 25 people that actually engage with any of our posts. So we sent out a friendly reminder email to encourage our board to engage however they can. Certainly continue to encourage everyone to do so, and create a profile on the forum, perhaps introducing yourself at some time, or sparking discussion however you can. That concludes it, unless anyone has any questions.
Great, and we're excited to see the forum. I also have to get more involved in that. Lori may know that we are trying to engage with working with ASPEN, or American Society of Pain Neuroscience. They share the same management of their sites and meetings as we do with Mantra. And there are many people on that group that are involved in the EPA. I think there's a real opportunity, given their focus on more interventional therapies and our opportunity in more multimodal, bringing things together, as Chris said. So it's something we are exploring. There's an opportunity to grow membership, and I think synergies between the leadership in the two groups. So that's just something in the works that I wanted to at least share with everyone.
Dr. Mehta, I think it's time now for Dr. Schmidt to come on with the tribute and then the election results.
Very good.
And hi, this is Bill Schmidt. I'm going to share my screen. Everybody should be able to see this right now. We have learned in the last year of the passing of two prominent members of the pain community. So this is actually the first time that we have had an in memoriam. We do have, of course, lecture series such as the Bonica lecture series that recognizes people who've been critical towards setting up pain medicine in the past. But there are two people that we want to recognize with words in silence for their contributions to the Eastern Pain Association specifically, or to the pain community as a whole. So I'm going to just go to the next two slides with about 30 seconds per slide. I'll allow everybody to have a chance to read the slides and to think about the impact that these particular people have had, either on you personally. If you are based in New York and are familiar with the Eastern Pain Association, you'll recognize the first person that we are going to recognize. And then the second person should be recognized pretty much worldwide for his contribution to pain medicine. And with that, I think it's my privilege now as the parliamentarian of the EPA to go on to the next portion of the program, which is to introduce our new officers and members of the board of directors and the nominations committee. So this is based on the election that we've just held. We hold an election every 2 years for the key positions that will govern the EPA for the next 2 years. And starting with two positions that are not on the ballot because they have been elected in previous years. We have a history of of electing a president-elect who serves for 2 years in that position before becoming president. And so you've already heard from Dr. Neil Mehta as our incoming president, and you've heard from Dr. Chris Garibo as our current president, who will become, at the end of this meeting, our immediate past president. So based upon the election results, I'm pleased to announce that Dr. Peter Laskaridis will be our president-elect for the next 2 years. The secretary will be Dr. Yu Chu, who is at Christiana Care in Wilmington. So I've also listed their affiliation. One of the things that I'm particularly happy to see is that we have members from many different medical institutions who are going to be on our board of directors for the next few years. Our treasurer is going to be Dr. Baruch Kim. And then going on to the members of the board of directors, Dr. Argoff, Dr. Wong, Dr. Michaelson, Dr. Sekri, Dr. White, Dr. Witkin. Several of these are people who have been on the board in the past, and a few of them are new members, which is also something that's very encouraging to see. And finally, members of the nominations committee who help with preparing the ballot and selecting the people for running for positions in the future. Dr. Charles Interisi and Dr. Michael Weinberger are current past presidents and members of the nominations committee for this year. We also have 2 non-board members by statute, and Dr. Durbhakula from Johns Hopkins and Dr. Gritsenko from Montefiore will be our non-board members who will help with the election 2 years from now. And that's the end of the nomination and election procedure.
Well, I'd like to congratulate the new board, and I thank the outgoing board for all their help. I look forward to working with the team and everybody that is so passionate about the EPA. And I see plenty of great opportunity to continue to grow the EPA as a pain society, a prominent pain society, as we have seen. Thank you, Bill, for putting together and running such a wonderfully rigorous election with no counts or recounts needed. And thank you again to Lori for helping to organize this.
Sure.
Very honored for myself for the position, and I just excited to see how the EPA grows and to continue in the leadership of Drs. Garibo, Dr. Mehta, Dr. Shaprin, bring new exciting accomplishments as a body.
And I would also like to thank everybody, Dr. Garibo, Dr. Mehta, and Dr. Laskaridis, as well as Lori and the EPA team. Humbly accept, and I look forward to working with the EPA team and growing it to bigger and better heights.
Thank you. That is Dr. Yu Chiu, although it says Baruch Kim twice here.
I gave him my password. That was Yu Chiu. This is Baruch Kim. It's an honor. I'm super grateful for the opportunity to be able to serve for the next, to be able to continue to serve as one of the executive committee members for the next 2 years. And I'm excited to be able to contribute, and I cannot wait to make a further contribution to the growth of the EPA.
Congratulations, everyone.
Fantastic.
Thank you very much.
Thank you.
Thank you all.
Dr. Mehta, do you want to have any closing comments or anything else?
No, I think we had a wonderful virtual meeting, and I look forward to a healthy and prosperous 2021. I wish everybody a wonderful holiday season, and we will plan to meet again in January as a board to start our work.
Yes, indeed.
Congratulations, everyone.
Congratulations.
Okay.
Thank you.
Congrats.
Thank you, everyone, and have a good
Happy
evening.
and healthy, everyone.
Okay.
Yes.
Happy holidays.
Happy holidays.
Enjoy your holiday. Yeah, bye-bye.
Bye now.
Thank you. Bye.